So thank you, Rory, for those kind words of introduction. Good afternoon, everyone, both face to face and for our virtual audience, wherever you may be this afternoon. Everyone's very, very welcome. So on behalf of Shane and myself, it's an honour and a delight to be here this afternoon and to help the cystic fibrosis community in Ireland with some issues surrounding microbiology and also probably infection control. Also, we want to conclude the CF Ireland Superbugs webinar series, and we've got a couple of slides looking at for questions that were asked in relation to non-tuberculous mycobacteria and also to travel. And following that then we open the session up for questions and answers if anyone wants to ask questions. And we're also joined this afternoon by colleagues from the Mater Hospital, Professor Hannon and Dr. O'Donnell. They are microbiologists as well. So what I'll do is I'll move across and let Cherie introduce the Mentimeter session. So thank you.
As you will remember from the session in the main room this afternoon, we asked a lot of questions from people globally about infection-related issues, infection control and cross-infection. And there was quite a number of comments that came back to us. And I think those comments we really do have to listen to, because there were a lot of infection-based questions. As John said, we got 50 questions sent in from CF Ireland that either PWCF or parents or friends of PWCF really did want to know about infection-related issues. Now, commonly, the microbiologist, although we sit in the multidisciplinary team every week, generally the PWCF and their families don't often get to meet us. So because there were so many questions that came in, we thought it would be good maybe to probe that a little further and find out, does the CF community have the opportunity to meet with the microbiologist from the lab to ask them the questions that are probing and of concern for them. So what you can do is on your phone, you can log into mentimeter.com, and then you'll be asked for a little code, and it's up there. It's 13780539, and when you type that in, you'll see those questions. And if you want to answer them, that's fine, but there's no way, we don't know who you are. It's completely anonymous. So we'd like to get maybe some feedback from you. And so do you have an opportunity to meet your microbiologist to ask those questions? And the people at home can do this as well. Okay, so out of the people who have answered the question, no, they have never had the opportunity to meet the microbiologist, and that is something which we personally as microbiologists ourselves, we like to try and get opportunities to meet with PWCF and their families. And during the COVID pandemic, there has been more opportunities for that to happen, because of meeting the patients using Teams, etc. So there's great opportunities to expand on that and maybe feed that back to other CF centres that there's just not that opportunity currently available. So the other thing is, maybe you don't get to meet us or you don't get to meet your microbiologist, but would you like the opportunity to meet the microbiologist? So it looks like that you want to meet the microbiologist, which is nice to see, because as I say, we're sitting in our laboratories and nobody wants to speak to us. In fact, when we came in to the hotel yesterday, there was many people from CF Ireland running up to us with the alcohol gels, and I don't know if it was because we were microbiologists that everyone was a little concerned about our presence, but it is good that you would like to meet us. When would you like to meet the microbiologist? And that's a free text. So you can type in when you think would be the most appropriate time to meet the microbiologist. So for example, would you like to meet them at annual review? Would you like to meet them regularly attending clinic, or when you're an inpatient? When would you think would be the most suitable time to meet the microbiologist? So it looks like there's a number of different key gates, if you like, when they're ready to party. Have you heard about our parties? So I think there, there's annual reviews when you're an inpatient or your child is an inpatient, when an exacerbation and a transition. And I think transition is probably a good point as well to meet with the microbiologist, because the child is now becoming a young adult. They're taking care of their own health care, and sometimes I know some families can feel a little left out at that point, and it's hard to give up the reins, and that it is a period that perhaps is maybe a little bit risky, where infection starts to creep in, if particularly adherence starts to slip, when the young individual starts to take hold of their own health care. So it's really good that there are different situations where you think it would be appropriate. Within our own centre, generally when we meet the individuals with CF, it's because they have some burning question, some burning issue, or perhaps they have a very unusual infection, and they've Googled it, they've tried to find out what does this mean for them, but they can't find anything that really explains the situation, or should they be on medication, etc. And many times that centres around the NTMs, and there were quite, as John said, there were quite a number of questions that came in from CF Ireland in relation to NTMs.
Yeah, I suppose also the other, where we're seeing a lot of traction now, is interaction with our social workers in terms of housing issues, in terms of fungi and environmental issues, where people are concerned about fungal growth or damp in their homes, especially following that very tragic case in England with the little boy who died from fungal related exacerbations with his asthma. So we're seeing new interactions between the various different members of the MDT in terms of where the PwCF including have got those specific questions.
And I see someone else has put in starting school or college, and as I said earlier on this afternoon, that there was a great need for information to be provided to higher institutions, levels of higher education, maybe going to technological colleges, to university, and people undertaking maybe some apprenticeship courses as well, where you have to go out into the workplace as well. It's not a legal requirement for anyone to tell the university or the college or their employer that they have cystic fibrosis. But we always encourage the PwCF to be open about that, because generally, particularly at the universities, they really do want to help out, and they want the student to obtain the goals that they are aiming for. And I think a lot of the infection control, cross-infection guidance that's in the college document can also be, to some level, also applies to the school situation as well. And we're increasingly seeing more PwCFs being in the same classes at school, being in the same university courses. The globe is a very small place, but particularly, certainly in Northern Ireland, and the same would be in Ireland, that everybody knows everybody. But sometimes that causes a problem. And then what happened in our situation was that a couple of patients knew that they were going to be doing the same course at university, and this caused them great stress and great concern. But the bigger question was how many other people with CF were also on that course as well. So it is important that universities and colleges understand what CF is and what measures that they can put in place, even from small things like who uses which toilet facilities, who uses which lifts, and the kind of practical classes perhaps that they're involved in, and is there any risks associated with the activities they would be doing, and also maybe going on field trips, etc., and insurance for going off on those field trips. So universities, schools and colleges need to be aware of those issues. So what topics, now we know we had your 50 questions, but in general, what kind of topics or issues is it that you would like to discuss with your microbiologist if they were available to you? So about resistance, perhaps John has scared everyone this afternoon. Choice of antibiotic. The best way to destroy my germs. Antibiotic toxicity, are the new ones still an issue? How to calculate risk in a social setting? Is Milton okay to sterilize the nebulizer? I think about the question about the Milton and to sterilize the nebulizer. There are some papers on chemical disinfection of nebulizers, and whilst it may be effective to a certain extent, as steam disinfection, heat is the best way to sterilize a nebulizer. Milton does have a problem with the fact that it can actually damage the nebulizer, and it can particularly damage the nebulizers, for example, that have a vibrating mesh within them. So there are some issues with using Milton in those situations.
Yeah, I think, and just to back that up, the issue with any of those cold chemical sterilizing or rather disinfecting procedures is that if you think if you were to take a nebulizer and to look at it under like an electron microscope or a microscope, through time, you know, there'll be certain etches and tarnishes and things like that on it, and that's where the bugs can hide. So if you've got a bug, think of it like maybe like your chopping board at home. When you put the knife down your plastic chopping board, it will leave a channel. And the bugs then can actually hide in there. And it's a bit like, you know, when the storm goes over the top of them with fire, they can actually remain viable inside and protected, because it's only a chemical sterilization process, unlike steam or heat, which is a physical, or irradiation, which is a physical process which goes through the entire matrix that they're embedded in, whether it be plastic or metal or anything like that there. So I think it's always safer to use a physical decontamination method, because you're, provided you use it correctly, then you're sure of the transmission of that force, whether it be heat or radiation. So for example, most medical devices, you know, will be sterilized using gamma irradiation, you know, in a factory, in a facility. And so whenever the PWCF or the general hospital patient gets them, then you've got the certainty that that's sterilized that product. As with steam, or sorry, with the cold sterilization method, there's always that issue that if the nebulizer is old and a bit what's the word, with plastic, you know, etched, that you may not catch them all.
And then there's, I think you'll be covering that, John, and going on holiday with your nebulizer.
Yes, so we're doing that.
With regards.
The travel session.
Yes. And then I see here there's, when is it safe to eat bread and toast, something about aspergillus? I think that's probably Caroline has started that. And it was about eating toast that had gone by its use by date, which could have spores of aspergillus in the toast. And some people find that kind of toast really tasty. But it does pose a risk because you can't always see the spores of the aspergillus. If you can see the aspergillus on your bread, there's a lot of aspergillus there. So it's best not to eat moldy bread, and it's best to try and eat it within the use by date. And again, the aspergillus is raising its head again there. Is it safe to have a compost heap, or is that an aspergillus risk? And that would be an aspergillus risk as well. And there actually could be some other organisms in that compost heap as well. So personally, John, what would you think in your opinion?
Yes,
I think it's a risky.
Yeah, what we try to do is we try to sort of minimize the exposure of the PWCF to potential, microbiological risk. If that's with bread, we've all done it. You go on holiday and you come back and you open the bread bin, and what's in the bread bin wasn't what was in the bread bin 2 weeks ago. You've got this sort of kaleidoscope of colour, of yellows and blacks and greens, of all these different fungi, Bucor, Rhizopus, Aspergillus, Penicillium, all sorts of different fungi in there. And we all know that fungi, it doesn't sit well, with PWCS, especially sort of in the transplant setting. Fungi are sort of public enemy number one. So I think, whether it makes good toast or not, I forsake that. I get fresh bread, or I think you can toast from that.
So there's a few other questions there. Perhaps we should deal with, should we? Yeah.
Yeah, people have asked them, yeah.
So, is it okay to wait in a respiratory clinic waiting room in terms of cross contamination?
Okay, well, obviously, again, the principle of trying to keep the organisms away as much as possible from different PWCFs. So for that reason, the CF community, had a hard lesson to learn after the Burke-O'Leary capacia outbreak. When we go back to the very first slides Philip showed today, that back in 1969 in Crumlin, where we had lots of little children with CF all standing together. And I've seen another PWCF, showing a picture of an early a CF program in Gormanstown in County Meath. And all the children with PWCF were all sitting on a tree trunk, a bit like in that picture, the scaffolding in New York, they're all 15 of them are all sitting having their lunch. And we didn't know the issues about cross infection back then. And we learned a hard lesson in the late 90s, late 80s, 90s, with Burke-O'Leary capacia in the summer camps in Ontario. And we saw that global outbreak of very virulent outbreak of Burke-O'Leary capacia infection. And for that, there was lots of infection control lessons learned, both at a clinic level and at an individual level. So what happened was, we then segregated clinics in terms of having a clinic for capacia, having a clinic for Pseudomonas, having a clinic perhaps for NTMs, depending on the number of NTMs of PWCF with NTM in your particular a clinic or hospital, and then maybe having a clinic for others. So once we cohort those people into those different organisms, then we still have to be careful, because going back to my talk, using the analogy of the Mini, yes, they're all Minis, but they're all different Minis. One's an electric, one's a diesel, one's a petrol, one's a 4-door, one's a 3-door, one's an estate, all this sort of thing. So there's a lot of variation. And because of that variation, we can't assume that they're all the same, because we do know that, some of them can be very, very sensitive. So for example, in early acquisition Pseudomonas, generally from the environment, those Pseudomonas are very sensitive generally to the antibiotics we use, because they haven't really seen them, living in the compost heap or living in the water, or the fresh water where you're swimming, or you're doing water sports or something like that. They generally tend to be very sensitive. But as they are exposed to antibiotics, it's a bit like Newton's third law. for every action, there's an equal and opposite reaction. So if we use antibiotics, then we will see antibiotic resistance. That's a natural phenomenon. So what we try to do then is say that they're not all the same. So that's why we can't let people, even with Pseudomonas, all come together. So we have to then think of mitigations, but we also have to think of the physical estate and what's realistic with keeping people safe. So another way around that there would be, certainly in some institutions, I think in America, the idea of using masks with PWCF is a lot more common than it would be in Europe. I think it's normal practice when the PWCF goes into a clinic in North America, the first thing goes on is the mask. What we can do then is we can actually then try to stagger people, so we don't want this sort of whole collection of people all sort of coming to a bottleneck, a clinic. And what we then do is the old system was we put the PWCF went around all the different specialties. We've stopped that now, we put the PWCF in the room, and then all the specialties come around PWCF, and we then give ample time, good ventilation to vent the room. So I think there's lots of learning for healthcare professionals and how we set up clinics, and also then the expectation, of wearing masks, and that's probably a cultural thing. I don't know what would be a question of how do people feel about wearing masks. Certainly the post-COVID, we certainly in Belfast we encourage mask wearing amongst PWCF. So certainly all the healthcare professions, we always wear a mask. When we're at clinic, anywhere in the hospital, masks, even relatively post-COVID. I say that with a small R. We're all still wearing masks in the hospital. So I hope that helps in terms of allaying some fears.
So one more question, just it's not up through the poll, but it's coming in through, is why would you like to discuss with your microbiologist? And one is, I would like to know if the strain of my Pseudomonas has changed. Just you don't see it on the screen here. It's not on the screen, it's just coming through a chat. So,
okay.
Yeah.
Well, whenever the PWCF expectorates, it's been alluded to today that's it's getting sputums becoming more and more difficult. I think you're going to put us out of the job, because we're not going to have as much sputum anymore. And we have to think, getting sputums are really, really important, or getting a specimen is a really important issue, in terms of whether that's a freshly expectorated sputum, which is easy to obtain, whether the patient is dried up and it becomes more difficult. And there is a study from Cardiff. I think it was Ed McCone talked about the SNOT 20 study. This is called the SPIT study. I think they're looking at induced sputum as a means of trying to get a specimen. As microbiologists, we can't do anything without the specimen. And then if you go into a more extreme situations, for example, when you're looking for organisms in the post-transplant scenario, then it becomes absolutely vital. And then you're into things like bronchial valves, bronchial lavage specimens. We then look for organism and sensitivity. But what we don't do at this stage in terms of the routine culture is to then type, I think that's what the questioner is alluding to, we don't type the particular organism and feed that information back to that person, because I think probably the question would be, well, what benefit, what added value would that show? I think what it would show is, are you having the same organism, or are you having, the same strain or a different strain? And the problem comes from, sadly, the late Juliette Vollraker. She did some studies, a microbiologist from Papworth Hospital, and published those studies in the Journal of Antimicrobial Chemotherapy, and showed that there, at any one given time, when the music stops, there could be several different types of Pseudomonas in the lung at one given time. So that puts the onus back on us as microbiologists to make sure that we try to capture that diversity in the ecology of the Pseudomonas, or the Stenotrophomonas, or the staph. And so at this stage, that level of detail isn't available. It's available when people do epidemiological studies in the hospital to see what's the range. Is there unique strains, or are there common strains? And if there are common strains, how has that commonality been arrived at? Was there issues of cross-infection and things like that there? So I think for the questioners, to answer the question at this stage, that level of information can be available. We've got new techniques such as molecular techniques, also whole genome analysis, but at that stage, that's not done, on every sample every time.
So, and there's another question there, do jacuzzis and hot tubs pose a risk? And the answer to that is one of the most riskiest kind of activities to participate in. And there is can be a lot of Pseudomonas in those hot tubs and jacuzzis. And another thing which was common just before the pandemic, I went on holiday to Thailand, and there was lots of these places where you could go and dip your feet in to these tanks where the little fish come and eat the skin of your feet, and those have been associated with outbreaks of NTMs. So where these kind of activities, hot tubs, jacuzzis, going on holidays and kind of playing around in these water little fish tank things, there are risks associated with those kind of activities. There's one there about the risk in an aeroplane, and I remember we prepared an answer about that, so we'll answer that in the next set of slides. Effective treatment for NTMs in pediatric patients. Is there anything on those slides that we prepared before?
No, I don't think so. There's lots of different guidelines out there. There's the British Thoracic Society and there's the American Thoracic Society guidelines for the treatment for NTM infections. And most folks would use one or other or a hybrid of that. They're again very much depending and been driven by the susceptibility, of the strains that come back from the reference laboratory, because susceptibility testing and mycobacterium is a very specialist type of operation, and certainly we rely on our reference lab to keep us right and inform us in that one.
And I think the treatment for NTMs is quite complicated. It requires quite a number of different antibiotics to be given. And initially, unless there is a decrease in lung function or there is some evidence on X-ray, it's not the kind of treatment that you enter into lightly, because you have to make sure that the NTMs there are just not bystanders, and that they are having an impact. They are causing an infection issue within the lung. Before jumping straight into treatment of NTMs, there's a lot of other things which have to be considered.
I suppose it would be interesting for Claire and Margaret to maybe jump in there and give their opinion on that.
I suppose the NTMs would become important, first of all, if we grew it once, we'd say, well, what does that mean? It could be a contaminant. So we'd like to grow it a couple of times before we might treat it. And also we would wait several weeks, months before we'd actually get the final result back as to what species it was or what it was sensitive to. So oftentimes we don't rush into treating these infections. We're very careful about that. But oftentimes it's only when you have a transplant that it's after the transplant you'd be concerned that it would come back. So we might treat you, might not be treated at all until maybe you're coming up to have a transplant, and you might get a course of treatment then, just to reduce the risk later on. But
I think that's a very valuable answer. And also one thing from the biology that's important for the CF community to acknowledge is that, Margaret alluded to it there, is that certain of the non-tuberculous mycobacterium grow very slowly. Some of them grow quickly, they're called the rapid growers, like abscessus, it grows quite rapidly. But some of them that could maybe take a week. But some of them takes, like avium intracellulare complex, they're slow growers. And that could maybe take 6 weeks or longer to grow, but like TB, where these things are growing slowly. And that's very different. The NTMs are slightly different biology compared to the likes of Pseudomonas, or Staph aureus, which grows up overnight. Next day, 24 hours, your plate's full of Staph aureus or Pseudomonas. That's not the case for the NTM. So I think knowing that biology, folks have to bear that in mind in terms of why haven't I got my result back? I did it last Friday. You take for these NTMs, it can take a long time. We can do things very quickly, like doing an acid fast stain, from a direct smear. But we want to do the whole picture and do the culture to make sure the result is a quality result at the end. So there's little nuances of the biology of the organism that do read across, in terms of expectation of PWCFs, that things don't always happen quickly because the biology of the organism simply doesn't allow it.
Excuse me, on MCM and is it true that if you've grown it and a couple of times, that it can hide itself for a long time, like go dormant, kind of go within a cell, it hides within a cell, and therefore it's undetectable for ages and ages and ages? Is that true?
It lives in the macrophages.
Yes, so it's an intercellular organism,
Yeah,
but also
so you never get rid of it. Once you have it, once you've detected it in your body, you probably will never be cure it.
Not necessarily. I'd say 50-50. There's a 50-50 chance you'll completely eliminate it with treatment.
Right.
And sometimes, it appears, for a few occasions, it's there and disappears itself. We never see it again. And so we like to follow these very carefully. But if you were to ask, if somebody was immunocompromised, then they're not able to kill it completely. So a small amount of it may live inside your macrophages, which is one of your white cells. And then when your immune system is down, it can come back again. So it's the same as tuberculosis. It's not the same. It sometimes it will come back in an immunocompromised
So
person.
you can be a carrier in the sense of NTM for a long time.
It can come back. There's a risk that it can come back. Yeah.
The final question is on modulators. Have they been able to see if being on modulators for a couple of years has helped the NTM decline in a patient?
I'd love to know that myself, actually. I would imagine it increases overall, it reduces the risk of infection overall.
Yes. I think coming back to your first point, which is well made, in terms of not finding it. That's one aspect, was it kind of hides inside the macrophage. And this is not unique to biology. There's lots of things hide inside other things. So for example, totally outside of cystic fibrosis, but if you think of the likes of Campylobacter, one of the most common food poisoning organisms, it can actually hide inside parasites. So, and it's very difficult because once it's inside, again, your chemical surface sterilization method won't penetrate it because it's hiding inside. But if you use heat, it's right there and kills everything. So that's one reason. The other reason is physically because the numbers are low, or it's hiding in different parts of the lung. And maybe the lungs aren't homogeneous. They're very heterogeneous. It might be up here, it might be down there. Maybe the physio's cleared a bit of sputum from the upper right lobe, but it's hiding down there. So kind of now you see it, now you don't. So, and the other thing is not so much with the mycobacterium, but with certain other gram-negative organisms, these, especially the likes of Pseudomonas, these things can form pseudosenescent forms. So basically, they go into dormancy. It's a bit like the bird hibernating. We do that very well with Pseudomonas, with these persister cells and these phoenix cells, because it's very, very advantageous for the organism to go into this pseudo-dormant stage. Because when the sort of the bushfire is raging above, they're hiding down in a burrow, letting it all pass, and then when the sun comes out again, then they can rejuvenate and regenerate. So there's lots of reasons why things grow, and don't grow. So I think we have to be very mindful of that. All of these pathology tests are not absolute. A negative doesn't absolutely mean a negative, because there are limitations to the test. So people have to be mindful, of that there. But it's important then that, what we think of then with these, the mycobacterium are tricky because they're different. Biology is very different to the other Pseudomonas and Stenotrophomonas, and these other gram-negative non-fermenters like Inquinalis or Ralstonia and all these Achromobacters and all these things here. They're they sit at the side, and we have to treat them with respect because the biology is different, how they grow them and things like that. So I hope that's helped answer your question. It's a fascinating biology.
Yeah.
You know, only if we know the biology can we then give the answers to these pertinent clinical questions. But as I agree
Yeah,
with,
and I just
Professor
also to
Hammond.
say that, you know, just because we grow them doesn't mean you can't have a transplant. No,
Yeah, that's something you always fear, because
Yeah.
if you get one of these, it's like, oh my God, it
exactly.
takes you out
There's
of the brain
nothing,
sort of.
yeah, there's no absolute contraindications. It will depend on how severe the infection is, what it's sensitive to. You know, we look at many different factors, but that in itself would not prohibit you from having a transplant. It's usually a combination of other things, maybe if there's renal problems and stuff. So, you know, so it's not an absolute contraindication to transplant.
but certainly,
That's a
yeah,
concern.
going back to the other session, you know, having a very resistant organism doesn't fit well with transplantation. Because post-transplant, whenever the patient's immunosuppressed, then you've got your armamentarium of antibiotics becomes very limited. So if that organism, you know, spills over in the case of the like capacious syndrome, and we start seeing sepsis due to that, because it's so antibiotic resistant, there's nothing really left in terms of our armamentarium. I think this is a kind of a misconception the general public have, that, oh, there's always an antibiotic for me. There's thousands of antibiotics. That's not the case. There's thousands of different commercial proprietary combinations of antibiotics. You know, this pharma does it, that pharma does it. They've got a fusidin, I've got a fusidin. But the number of antibiotics and the number of classes of antibiotics is relatively limited. So we're not starting off with a very healthy bank account with lots of different antibiotics. And I think we have to debunk this idea that there's always an antibiotic for me. There's thousands of them. That's not the case. So we have to be very judicious, and we've introduced new systems in terms of antimicrobial stewardship to try and, you know, use what we've got, that armamentarium, use that very judiciously, so that there will be always an antibiotic for people. But that's the whole wave of antimicrobial resistance. We can't be always assured of that.
I think there's just two more to get your viewpoints. And there are a lot of medical terms associated with microbiology and infection in CF. And something which has come out of the 50 questions again, when John and I have been trying to answer your questions, we found that we've had to think about how to express things in a different way, because there's some microbiological terms that we would use, but not necessarily everyone would understand those. So do you think a glossary in patient-friendly or in layman's terms would benefit the CF community to have? Because that's something we could have a look at, and in conjunction with CF Ireland, we could build up that glossary for use. So it seems to be, that's a yes. Yeah, that's a yes.
That's carried.
And I suppose we can look through the questions of the kind of terms that you would like put in that glossary. I suppose in the interest of time, we wouldn't really have a lot of time today to kind of think about all those glossary terms. And I think that's something maybe we can set up with CF Ireland to find out what kind of terms you would like in that the glossary. So that we're given the CFI community plenty of time to think about it. It's probably a hard one to ask on the spot. And the final question I have is, how important is cross-infection control and infection control and prevention of cross-infections? Now there's 1, 2, 3, 4, 5 different scenarios before the era of the CFTR modulators. How important do you feel infection control was? Now that we have the CFTR modulators, do you think that it's the same, or you can be a little bit more risky? And in the hospital and in the home and in the community. So it is interesting to note that you have a difference of opinion in terms of infection prevention, and whether it's in the home, the community, the hospital, and there's a slight dip there in the era of the CFTR modulators. So I think that is something as microbiologists that we would like to keep to reinforce with the the CF community, that all these areas, infection control and prevention, is very important, and they all have equal importance. So that's something that perhaps as a team and as a group, we need to maybe look at in a little bit more depth.
Yeah, I think that's an important one, you know, the idea of, you know, can we reduce the rigor of infection control in the era of CFTR modulators? And I'd say at this stage, absolutely not. Until we've got evidence, the status quo remains, you know, really infection control, cross-infection prevention, you know, all the way. I think it's really, really important to reinforce that. You know, we can't, with these organisms, we can't play chicken with these bacteria. These are serious organisms, you know, and we have to maintain that stringency, you know, of avoidance and being on top of them all the time. Maybe when we get more data, I don't know, but certainly at this stage here, till the absolute date, we can't change anything. So it's the status quo. I think I feel has to remain. What about our colleagues from the matter? What do you feel? Sure.
Yeah, no, we know that it's, I think we can't ignore infection control. I think it's the bread and butter of, and I think particularly with antimicrobial resistance, I think we just can't ignore it.
Thank you. Okay, I think in the interest of time, I think there was a lot more questions with regard to travel that seem quite common. So one of the 3 questions that have been asked previously and also today, are there any special precautions which a patient with CF should take when going abroad so as not to acquire infection? Any tips for keeping the bugs away during air travel? Become very probably very timely in the event of COVID. And how should I clean my nebulizer when on holiday? So what we always like to do in these webinar sessions is provide an answer, but provide an answer which is an evidence base. This is not just what John and Cherie thinks. This is what John and Cherie is conveying to you from the literature that has already been published, the most relevant literature, to help you give an informed, for us to give an informed answer and for you to make an educated decision as to how you move forward with that activity. So I will, you know, we will direct you to this paper here. It's quite an old paper. It's 13 years old this year, but it's still a very relevant paper. And that's from the ECSF, the ECORN study group, with Stuart Elburn and Judy Bradley. And this is an important paper. The DOI is down there. If you click on that DOI, that will bring you to the paper. This paper is open access, so there's no subscription required. And there you can find out, you know, all sorts of important things. Within that, there is a table 5, potential complications of sports activities. So there, that paper, in an evidence-based fashion, lists the sport and lists the complications. So ball sports, bleeding from esophageal varices, you know, rupture for the liver and spleen with soccer, and so you go and you can see, you know, non-infectious things like fractures. But also you look at things like water sports, there's Pseudomonas in the pool. You also look at, you know, the likes of ABPA for horse riding. The issue of compost came up earlier on. You know, we know with hay and compost and whatnot, we can see aspergillus. Where you see aspergillus, that potentially could exacerbate ABPA. Also, you know, other issues like Cherie mentioned before, sauna and hot tubs, where you've got the incidence of these Pseudomonas organisms. So hopefully that, whoever asked that question, hopefully that will be, you know, an evidence resource to answer their specific questions. Also, the Cystic Fibrosis Foundation have provided some valuable evidence here, and there's the link to this information here. What the CF Foundation are suggesting is that always wear a mask, protect yourself from airborne germs by wearing a face mask. So use the overhead air vent to blow airborne germs away by setting the vent. Washing hands, general good infection control advice, you know, keeping your hands clean, washing your hands, and then using a 60% alcohol-based hand gel, drinking bottled water, avoid touching eyes, nose, and mouth, wiping down the tray table, avoid touching surfaces in the aircraft bathroom, so on and so forth. There's a lot of good information here. Also, when you're on holiday, be careful when you bathe or swim. you know, in some areas tap water may not be even as safe for brushing your teeth, so use bottled water. Avoid, you know, water where animals are drinking or wading, swimming pools or water parks that are chlorinated. And avoid hot tubs, jacuzzis, and areas, you know, where there's a lot of steam and